Good afternoon, ladies and gentlemen. First of all, I'd like to thank you, Professor Celia, President of the Congress, for his kind invitation and kind introduction. And this is the first visit, of course, in Israel. That is one of my long-term dream to visit here. It is a good opportunity to experience holy places in the world. Today I have two topics. First topic is how to prevent complications in laparoscopic liver resection. Okay, control. How can I control this? Open up.
Open it up. לא, רוצה לפתוח את זה כדי שלכל המסך.
This is the full size. How about previous slide? Page up. Okay. Next down. So, first case of liver resection was done in 1886. But patient died by bleeding. And first successful liver resection was done in the 1888, but examination of the specimen that was normal. After that, now we are in the stage period of laparoscopic liver resection. As you can see here, first laparoscopic liver resection was performed by Dr. Gania in 1992. In the 1996, first anatomic liver resection was done by Husserl. I met him last month in the SAGES meeting, Azagar and Husserl. And the first robotic liver resection was done by Giulianotti. And as you can see here, after 2018, there is a sharp increase of laparoscopic liver resection in the world. The changes, the instances sharply increased, and the indication is a bigger operation, and the main indication from benign to malignant, and there is a challenging locations. Also, there is a decrease in morbidity. But there are obstacles to the widespread of laparoscopic liver resection until now. As you can see here, difficulty of reproducing techniques used in open liver resection, difficulties in retraction and mobilization, lack of technical familiarity, comfort with lapar equipment, and tedious parenchymal transaction, and fears uncontrollable hemorrhage and gas embolism. A margin of tumor are not always present, difficulties removing specimen, apprehension concerning the possibility of a port site metastasis. The absence of randomized controlled trial is difficult to try, and inertia are the obstacles of the widespread use of laparoscopic liver resection until now. There are many complications in laparoscopic liver resection: bleeding, gas embolism, bile leak, staple misfire, tumor seeding, and conversions. The two major complications are bleeding and gas embolism that are related technical problems. Strategies to control bleeding are meticulous dissection of parenchyma, gauze decompression, compression, vascular cramping, suture ligations. Laparoscopic surgeons should know how to use energy devices. There are so many energy devices and with improvement. As you can see here, we can use a Kusa harmonic, sonar surge, thunderbeat, new equipment usually developed. And for meticulous parenchymal detection, most commonly used equipment Kusa, we have to know the precise methods to use Kusa. And most commonly used control the breathing is a compression, especially cardiac compression. Also we use a hemostatic material. And you can see here, and we can use also bulldog clamping. And also we can use a Pringle maneuver to prevent bleeding during the liver parenchymal transaction. And another way is we can use a Tibeti clamp here. And we also use a bulldog clamp is a very important, effective method to control the bleeding. And also we can use suture technique if we cannot control breathing by the compression. Okay, suture ligation, the same, maybe same. And the summaries of bleeding control are: first, reduce the amount of bleeding as soon as possible. Grasp, cramp, compress the bleeder, and use simple hemostatic method, bipolar electrocautery, and apply hemostatic agent or gauge decompression as you already seen. And take adequate measure to obtain a good surgical field. Do not make surgical field bloody. Poor visual field make poor bleeding control, and further dissection if necessary. So skeletonization of bleeding vessel is very important to control adequate bleeding. And take general measure to decrease bleeding, increase intra-abdominal pressure, decrease tidal volume, and the Pringle maneuver if necessary. And important thing is take sufficient time to have exact bleeding control under good visualization. Do not be panic. Do not hesitate. And there is many report about the pneumoperitoneum, intra-abdominal pressure, but high intra-abdominal pressure can reduce bleeding, but there is risk of gas embolism. Usually gas embolism not so serious, but as you know, as you can see here, intra-abdominal pressure maintained less than 12 millimeters, usually no problem, but sometimes even such a low pressure can cause gas embolism. Low peritoneal pressure to CVP gradient and safer surgical technique, avoid hepatic venous injuries. Hepatic venous is the most serious complication, shorten operative time. You can see here. And pneumoperitoneum and managing intra-abdominal, we need a flexible approach at applying intra-abdominal pressure. You can see a balanced intra-abdominal pressure and CVP. Intra-abdominal pressure, CVP increase bleeding, but CVP increase risk of gas embolism. Usual gas embolism not associated, but argon beam, when you use argon beam, there is risk of fatal complications. So managing intra-abdominal pressure is very important to balance between bleeding and gas embolism. balance is key. And tidal volume and CVP, as you can see here, decrease 10 to 20% tidal volume is very important to control the bleeding and also control the gas embolism. And another thing is staple misfire. Two safety tips are create adequate space around the major vein before introducing vascular staples, and never pull the hepatic vein, which might avert the vein from IVC. There is a report of a mortality cases. Always have a vascular clamp ready and under vision intracorporeally. And finally, the effect of learning curve is very important. As you can see here, 60 cases for minor hepatectomy, and major hepatectomy, another more than 15 cases. But in large volume center, it is not so big problem. But low volume center, it is very difficult to have such many experiences. So one easy way is to visit a large volume center. And summary, to prevent complications in laparoscopic liver resection, a sufficient experience of open liver surgery, that is very essential and important point, and sufficient experience of general laparoscopic surgery, and also through preoperative anatomic review of CT, MRI imaging is also very important. And the ability to control bleeding and reduce gas embolism is key to boost a major laparoscopic hepatectomy and improve outcome. So enjoy it always if you cannot avoid it. Thank you.
Any questions from the floor? I have a short question. How do you deal with the technical challenges of laparoscopic liver surgery, which include maintaining plane of dissection, which I find sometimes difficult when you do a laparoscopic liver surgery and you tend to skew away from your plane of dissection? It's sometimes, I find it more difficult in laparoscopy than in open surgery.
You mean the laparoscopic or open?
Yeah, when you do a laparoscopic resection, yes, and you plan a plane of dissection, and then you tend to skew a little bit from your plane, and you may come across tumors or...
In the same in open surgery, if you want to do a, for example, right hepatectomy, so you can follow demarcation line, but recently there is a induction of a fluorescent technique, ICG technique, so you can find out the ejected incision line, cutting line. And another very important point, whenever there is most serious complication always associated with hepatic venous injury. Mm-hmm. When you approach in the hepatic venous branch, you have to cross over parallel to the vein and not go to directly, but caudal approach. So branches of venous always like this tree. So you can approach separate approach. There is always a tearing of branches, so causes bleeding. So most important is a caudal approach, and then you can control breathing. And also skeletonized vessel, front and back space. So you can insert, in case of bleeding, you can encircle, identify vessel completely. So it is a very important point to prevent massive bleeding.
Thank you. Okay, the second talk.
Thank you.
Thank you.
The second talk will be laparoscopic liver resection for HCC.
My second title is Laparoscopic liver resection for HCC. Where are we now? As you can see here, a endemic area of HCC in the world are Orient, China, Korea, Japan. I think Israel is not so many cases. And already you have know this. And after 2008, first international consensus meeting, 2014 there was a second meeting in Morioka. This is the largest review of laparoscopic liver in the world that confirms in growing safety when performed in selected patients with a trained surgeon, very important. So improved patient short-term outcome compared with open liver resection are already confirmed. But the proper training are the next challenges of laparoscopic liver resection now. As you can see here, reporting articles increase, also the number of laparoscopic liver resection increased continuously. And the most common indication is hepatocellular carcinoma here. And major laparoscopy is right hepatectomy, and major resection also increase rapidly. And the goals of laparoscopic liver resection for HCC are minimal invasiveness, safety, feasibility, and finally curability. And the advantages of laparoscopic liver resection for HCC are more smart operation, less bleeding, low morbidity with similar mortality, and short hospital stay, and no oncologic disadvantages, less adhesion that make redo or subsequent liver transplantation easier, but we need more experience and skill. Recently, another issue is laparoscopic anatomic liver resection possible? As previously mentioned, experienced surgeon can do the same technique with open surgery. And as you can see here, there is many propensity score matching analysis in Korea and Western country. There is no survival difference between two groups. This is a Japanese report and propensity score matching in multi-institutional study that also confirms less bleeding, short hospital stay, low water complication morbidity. Also another report that matches major hepatectomy with match paired analysis also showed that there is no difference between laparoscopic liver resection and open liver resection. This is the first case in Korea. I had done right hepatectomy through anterior approach. As you know, the anterior approach has many advantages. Best studies and report from Hong Kong group. It is initially invented in Kyoto group when I was there. We'll skip over so there is a critical point: hepatic artery, portal vein, and bile duct, and then during the parenchymal dissection, branches of middle hepatic vein, V5, V8, we can identify easily. Then we can identify right hepatic vein. If you can find out that three important structures, there is no risk of massive bleeding during the major hepatic resection. That is a key point. So recently, the Japanese group introduced a caudal approach, similar, I think. This is the redo laparoscopic liver. With the experience of laparoscopic liver resection, we can do repeated liver resection. Repeated liver resection. This is a repeated. There is a video clip not moving. This is second operation. As you can see, there is no adhesion like a open liver resection. As you can see here, a review of the repeated liver resection for recurrent HCC. There is decreased operation time, decreased less bleeding, and short hospital stay. And summarized, in highly selected patients, repeated liver resection for recurrent HCC is feasible and safe. Comparative studies show demonstrate that repeated resection is superior to open repeat liver resection in terms of perioperative outcomes such as decreased blood loss and length of stay. And as evolution of technique from hand surgery from surgeon's hand, open laparoscopy, now moving to the robotic surgery. As you can see here, there is a compare of robotics and laparoscopics. Breathing is less in the open laparoscopic surgery. Also, a operative time. Also, robotic liver resection has a long operation time, and there is no difference between hospital stay in conversion ratio between two groups. The resection margin is less. Laparoscopy is better, and in the morbidity is less in robotic. But this year there is another meeting. With the experience of robotic surgery, the operation time is shortened with the experienced centers. There was a consensus meeting about the robotic liver resection for HCC last year in Singapore. In summary of the consensus meeting here, there are no evident advantages using robotic approach for liver resection. Learning curve of robotic is probably shorter because they have already experience of laparoscopic liver resection. A reduced blood loss of operation time should be anticipated in the laparoscopy, but experience robotic surgery that is also shortened became better and better. There is no difference in terms of margin with conversion rates and general morbidity and hospital stay. In another advanced centers, they also a single port laparoscopic liver surgery. In Korea, one surgeon they did more than 200 cases already, but recently he personally announced it's very tedious job. He abandoned to carry out single port liver resection. So there was, as a second international consensus meeting in Morioka. At the meeting, the most important remarkable point is extent of typical score. As you know, there is a big accident in Japan, consecutive mortality in laparoscopic liver resection. So they introduced the typical score. The learning curve is already mentioned, very important. And the most important message from a Morioka meeting are to prevent a complication and prospective reporting registry for transparency and difficult scoring system to select patient and the creation of a formal structure of education they recommended. We had a laparoscopic meeting in our area. I have organized in 2015, and there was second expert forum of Asia Pacific laparoscopic hepatectomy in 2016 in India, and the third expert forum in last year in Korea. I have organized them. we have reported a summary highlights of third forum. As you can see here, application laparoscopy for liver surgery rapidly increasing, and past few years have demonstrated a shift in paradigm with a trend towards a more extended and complex laparoscopic liver resection. The development of instrument and technical refinements with the effective use of powder laparoscopic views have contributed to the ability to overcome the limitation of laparoscopic resection. So last month, there was during the SAGES meeting, there was a session of SAGES International Laparoscopic Liver Surgery Joint Symposium. As you can see here, in the near future, there is a big change in the OR, laparoscopic OR room, and another is we can accept a artificial null information, AI, so you can say future liver surgery may be another big change we can expect. So the goal of laparoscopic liver resection for HCC are same procedure as open surgery with a better outcome. To achieve the goals, the improvement of laparoscopic surgical skill and adapt to new surgical device and laparoscopic skill are very important. So I'd like to introduce, this year there will be second International Advanced HP meeting in Seoul. Thank you. Thank you very much.